The previous speaker showed that there's a lot of discrepancies, especially on low-grade dysplasia, but there's also discrepancies in pathology on high-grade or cancer in Barretts. And let's see why this is the case. Barretts is definitely the electrical toy train for surgeons, gastroenterologists, and also pathologists. And it's not clear why this is the case, because Barrett's is a small segment in most of the cases, just a few centimeters in the distal esophagus. Well, there are some cancer cases, but the numbers are not comparable to colon or gastric cancer. That's much higher numbers. But anyhow, it seems to be the electrical toy train. Lots of emotions, lots of problems, and let's see whether we can sort this out. So in the development of Barrett's, the initial event seems to be an injury, an ulceration. The first thing that happens then, it's a stem cell-driven process, letting deep gastric glands appear, pyloric gland-type cells, and then in a second event, foveolar-type cells appear, and that's nothing than surface epithelium of the stomach. So if you take these two blue bars together, you have nothing else but cardia. That's cardia mucosa. And then in some patients, we don't know in whom, we don't know when, intestinal metaplasia, goblet cells appear. And then we have the risk for cancer, right? But in the recent years, we found out that there's a shortcut. There's those foveolar, this cardia type of mucosa can also lead to carcinoma without any goblet cells present. So there seems to be a shortcut from gastric metaplasia right to carcinoma without the intestinal metaplasia, without the goblet cells, for what reason ever. And with no doubt, patients in the US have more goblet cells than European patients. It's not known why, and the smallest number are with Japanese patients. Again, it's not clear why this is the case. The Japanese segments are often lots shorter than Western segments. Maybe there are some differences in food or a genetic background or whatever, but that's probably the situation. So when it comes to this stem cell driven process, well, stem cells or stem cell concepts are very attractive because you can believe it or leave it. So you can explain everything or nothing because you can't stain them properly, you can't see them properly, and so there's a lot of still unsolved problems or issues around stem cells. It's clear that some of these stem cells stem from the cardia. It's also clear that some of the stem cells derive from the esophageal squamous epithelium or a bone marrow or the mesenchymal tissue underneath the squamous epithelium. And the role of the fibroblasts in the mesenchymal tissue has been underestimated for at least 100 years. Nowadays, we know that fibroblasts can even promote tumor growth, but also at the same time promote epithelial repair and mucosal healing, not only in Barrett's, but also in the stomach or in cases with ulcerative colitis, for example, and the development of neoplasia there. So the role of fibroblasts, it's huge, but we have overseen it for 100 years or so. The inter-observer variation you already heard about. Partly it's also due to the fact that we have different methods of reporting neoplasia. So it's also the wording. We're using different wordings worldwide. We do not have a uniform pro forma worldwide for reporting neoplasia. We need second opinions, and not even biomarkers really helped us. These genetic events here, they're known for a long time. And we thought this is so perfect, so we can confirm our histological diagnosis by some mutational analysis, and then we have a final proof what it is. So, but it turned out that when you bring down it to a single case, it doesn't work. Shown by the previous speaker with his data on low-grade dysplasia. 85% are downstaged in expert opinion hands. So and the issue is that, especially in Barretts, we have no key mutations nor pathways. We have a multi-step process towards the development of cancer, and we have a very heterogeneous situation, and that makes it so difficult to find neutral or objective markers for neoplasia other than an expert pathologist. So we were very happy when Rebecca Fitzgerald and her group came up with a 7 biomarker panel. The problem is it's mainly based on P53 and expert opinion. But to be honest, as it had been shown from the Amsterdam data on low grades by Walter Kurvers and Lukas Deutz, it's only expert opinion that really counts. The P53 doesn't play a role at all, because P53 accumulates not only in neoplasia, it also accumulates in reactive changes. And the distribution is a little different in neoplasia than in reactive changes, but it's besides this group that really loves P53, it's not really a game changer, because when you have a tiny lesion, you request from your lab a P53, and then the lesion is stepped out. So we do not have the material anymore to do anything on this slide. So we don't do it. I don't need it. It's fun to have it. If my colleagues love to have it, please do it. I'm fine with it. I personally don't need it because I think it's not more information that comes from P53 results than from the H&E. And this is also a very old table. It's only P53 that has some diagnostic use in experienced hands, but all the other biomarkers fail. The reason is because I already told you there's no real key mutation, there's no really key pathway that really proves something is neoplastic or not. And the reason is that especially Barrett's, it's already metaplastic mucosa when it starts to develop neoplasia. So this is no normal mucosa. So normal rules like elsewhere in the GI tract do not apply to Barrett's. And that makes it very, very difficult. And it's a rare lesion. So this makes it difficult in non-experienced hands when we do not see this, when people do not see this every day. The numbers are just too small to learn anything from that. And therefore, the second opinion issues appeared. By the way, the original description description of the term dysplasia stems from 1923 from Budapest. And it was defined by Eduard Krompecher as cells that look abnormal under a microscope but are not cancer. You know what? Still valid. We do not have a better definition today. Well, all our attempts with low-grade dysplasia and high-grade dysplasia to stratify the risk of development of neoplasia a little bit more, we do not have better definitions, because as you can see in the graphics, there may be some overlap zones, maybe depending on the daily performance of the pathologist, maybe depending on the sampling error issues. So it's a gray zone, and the real best definition we have is from 1923. Cells that look abnormal under a microscope but are not cancer. Coming to this tongue breaker intraepithelial neoplasia. Well, that's definitely a self-explaining term. It's a tongue breaker, but it's self-explaining. Why was there a need to change the term dysplasia into intraepithelial neoplasia? Well, because many colleagues used some adjectives in conjunction with the term dysplasia. And the best ones are the very last lines on this page. Diffuse dysplasia, globoid dysplasia, and we found even in a report strange dysplasia. It makes no sense at all to further subclassify dysplasia into such terms. And the only terms that I missed in this list were cataplastic dysplasia that was used in the 1960s and 70s, real dysplasia, and true dysplasia. So that there were many also reactive changes subsumized in the term dysplasia. And this is the problem also, and that differs worldwide. Some people are more to the reactive side to call something dysplasia. Some other people are more to the neoplastic side and restrict the use of dysplasia a little bit more, leading to 85% downstaging of low-grade dysplasia. When you look at the expansion patterns of neoplasia everywhere in the GI tract, not only Barrett's, also stomach or colon or normal, in the human body, all glands are parallel. They're very regular, they're very parallel. And once you see that there is a growth parallel to the surface, that glands, neighboring glands are connected to each other, then it's nothing else but invasion through the mucosa. And that is what you can see at the right-hand side of this scheme when these glands are growing, these violet glands growing towards this light red ones. So that's nothing else, an early sign of invasion. There's some other patterns, but basically it's always the same. Lateral expansion, intertubular fusion of these prior parallel glands, and then we have cancer. It's very easy. So why I'm telling you all this, in this picture, maybe some colleagues won't believe, but it looks very regular, but in the center here, this is cancer. There's a parallel growth here, and the glands are growing parallel to the surface. They're connected to each other, and same here. It's a very subtle, minute, focal case of cancer. It's very easy. The cytology helps a little bit, but you can't really say whether it's reactive. But the architecture of this lesion is cancer. It's a mucosal cancer. I do not need to see any single tumor cells or breakthrough the basal membrane, because very well differentiated tumors, carcinomas, they can build up their own basal membrane in the GI tract. So you don't see breakthrough the basal membrane unless you have a more advanced lesion. So why is there a problem if this is so easy? Well, the criteria that have been used to diagnose dysplasia or neoplasia or cancer, they have never been validated, and they are not accepted worldwide. It may be that you go next town and they tell you something completely different about how to define that a lesion is low grade, high grade, or cancer. I will show you a little bit later more reasons why this is the case. And if you see it neutral, there seems to be a very lower threshold to call something carcinoma in Japan. They call everything carcinoma. In the US, the total opposite. They do not call anything carcinoma, but high-grade dysplasia only, if you express it in a quite polemic way, so to say. Europe, a little bit in the between, depending a little bit where you have been trained and to which system your trainers were more attracted to, let's say that. And we're looking at different medical systems. In the US, a strictly outcome-driven system. And that means 0% relapse is the goal to go for. That means even larger operations are taken into account as a better solution than having just 1 or 2% relapses. In Europe, it's more, we do it the best way we can. If there are some relapses, then there are some relapses, but the patients are in follow-up. So we will operate on them later on. But the vast majority does not have a major breach of their quality of life, so to say, because we removed these lesions with little interventions, maybe just a local endoscopic resections. In Europe and Japan, we have all these criteria, what cases are eligible for local treatments, endoscopic treatments, and whatnot. So, and I'm not saying that the US system is worse and the Japanese system is better or whatever. It's different. It's not worse or better. It's different, and that is historically grown. We are looking at different systems, and now we have to see how to combine this a little bit. The first try to combine these two systems, or three systems, if you like, was the Vienna classification, when they grouped together some terms of diagnosis, some diagnostic terms, that led to the same therapeutic consequences. But they never really tried to assess the real reasons why we see these variances, why we see in some countries low-grade dysplasia being downstage for 85%, and nobody cares. You could do the same study today, and you will still end up with 85% downstaging. So there is something wrong with all these criteria that have been used. So in Japan, the diagnosis of neoplasia is mainly based on nuclear and cytological criteria, a little bit the structures and the appearance of the cells. And the result is definitely there's almost no discrepancy between a biopsy specimen and the later following resection. You could, if you put it this in a very polemic way, if you call everything cancer, then you have no then you have no observer variation anymore, because nobody is going for low grade, high grade, then they call everything cancer. This is the polemic thing. The criticism goes a little bit from the West, goes a little bit into this direction. Maybe this contributes to the high incidence of neoplasia in Japan in some regions, and the perfect prognosis of these patients. So nobody dies anymore. But you could argue very well in the other way, because it's early cancer that have been treated endoscopically. So the prognosis for sure is a lot better than a advanced cancer. In the West, we would like to see a breakthrough the basal membrane. I already told you that well-differentiated tumors can build up their own basal membrane. So this is no good criteria. Single tumor cells, no good criterion, because single tumor cells you see in deeply invasive tumors only. But in most cases, the vast majority of mucosal cancers, you have no single tumor cells. You have no poorly differentiated areas. It's very well differentiated. And you do not even see desmoplastic stromal reactions. That's also something very deep for deeply invasive submucosal cancer. And this is the problem. We're in the Western world, we're coming too late with our criteria. And that is the reason why many pathologists call something low grade on a biopsy, and then they call it cancer in the resection specimen. It makes no sense that even to the development of an own biopsy classification that is different from a resection specimen, because it's so complicated to diagnose neoplasia in a biopsy. No, it's not. It needs some terms, it needs precise criteria, and it needs experience. That is the lack in all of these studies that have thousands of low-grade dysplasias in consecutive series. Makes really no sense. But that, from the Japanese view, contributes to the lower incidence of gastric cancer, for example, in comparison to Japan, and the poor prognosis of these patients. The basal membrane, I already told you, and even the WHO defines it, the neoplasia is a breakthrough the basal membrane with a single tumor cells. I explained to you that this is the case in deeply submucosal cancer, but not on the mucosal level. That's just not true. And this, it has been known for a long time, mid of the 1980s. We all had this data about this lateral expansion, intertubular fusion, the basal membrane that is built up by the tumors. We have this knowledge, but it never found its way into WHO. So this is something where you can criticize the WHO. Here another example, a mucosal carcinoma. I showed, again, this parallel in the right lower picture, the parallel growth of the glands compared to the surface. If there's parallel growth towards the surface, it's cancer. It's invasion through the tunica propria, so to say. And that is lateral expansion, or synonymously intertubular fusion. So those are the criteria. Works perfect. Pathologists love to tick boxes, and then they come up in the end with a certain diagnosis. The only problem is these criteria have never been validated. These criteria are therefore not accepted worldwide. They're not used worldwide. People do it with their gut feelings, but not based on precise criteria. If you follow these criteria, it works perfectly. We know this. If you train people on these criteria, It works in 100%, almost 100% of the cases, despite some sampling issues or so. So who is wrong, who's right? Because I can tell you everything, and somebody else may come tomorrow and tell you the opposite. So the final proof is metastasis, vessel permeation, or death of patient of cancer. Well, in these very early cancers, there are no metastasis and there are no vessel permeations. I copied this table here from the WHO classification. When you when we start with low-grade dysplasia, it says that glands are slightly crowded. Please, what is the definition of a slightly crowded gland? What's the definition? Give it to me. You can't. Nobody can. But these are the criteria in the WHO. What is, please, mildly hyperchromatic? How to differentiate this from moderately hyperchromatic? These are so many ill-defined terms that leave so much space for subjective interpretation that this simply doesn't work. And this is the reason why the previous speaker explained to you that these 85% of low grades are downstage, because the criteria by the WHO make not even the slightest sense. This is a fact. Who I am to criticize the WHO? Well, that's a difficult thing, because the WHO is our blue book and it's our Bible, but sort of. But this is not working. This is the reason why it's not working. So let's give it a try. So I know that most of you are not pathologists. I understand. I do not show many pictures, but these two pictures here, this is low-grade dysplasia in the Western and in the Eastern world, Japan or whatever. The key feature is that you see these nuclei here. They look like a fence around your garden, palisading, hyperchromatic nuclei. I'm not subdifferentiated mildly or moderately or whatever hyperchromatic. It's hyperchromatic, it's dark, it's hyperchromatic, and it looks like a little fence around your garden. And all these cells, they look the same. So this is low grade, no doubt, even in my eyes. So in this case, this is high grade in the Western world, because you see some of these cells, they almost fill the whole cytoplasm. And some of the cells are rounded already, and they leave their basal position here. They're very large. So this is not low grade anymore. This is also clear in Japan and in the Western world. In the Western world, it's high grade. You know what? I call it cancer. You see these glands? They're starting to grow everywhere. They are not parallel anymore. They're already starting to grow sideways towards the next neighboring gland. And therefore, I call it cancer. And by the way, in Japan, this is called cancer also on the cytological level. But maybe this lateral expansion is a vehicle to combine the Western and the Japanese world, so to say, in diagnostics. That is something we can use. I have shown the slides in Japan as well, and explained in my words that they can use this, that we all can use this as a vehicle. And my Japanese colleagues agreed. This is an easy case. This is cancer. You see the single tumor cells here? So no doubt, even by the WHO, this is cancer in the Eastern and the Western world. So here, again, we have in the Western world, this is high-grade dysplasia. You see that these glands, that these nuclei here round, they do not look like your nice garden fence anymore. They have round, very big nuclei, no palisade, no real palisading anymore. Well, here's some palisading, but it's not, they do not really look uniform. Some of them are round, some of them are bigger, and it's not that much palisading anymore. You know what? I call it cancer. You see these two glands? They are connected to each other. They are branching. They're not parallel anymore. I would call this cancer. And you know what? It was a submucosal cancer. It was deeply submucosal. Here's the muscularis mucosae, and here's the breakthrough, the mucosal membrane. But I can make the cancer diagnosis already with two cells or two glands from above here. I do not need to see this. I can tell him here. And this is exactly the problem. In the Western world, the biopsy is called high grade. And on the resection specimen, even all Western pathologists could agree that this is cancer. I think you got the idea. And it's even worse, because we have cases that were signed out by the WHO, sorry, by the Western pathologists as high grade, but they showed in 4% submucosal invasion, even venous invasion or lymphatic vessel permeations. So it's our criteria on biopsies, they're not sufficient. It doesn't work in the Western world. We are not strict in the use of our criteria. We're not strict with the terms we use. This is a huge problem. So if you have if the percentage in Barrett's of neoplasia in your series, let's say for low grade, is more than 2% in the all patients. If you have more than 2% low grades, it's too high. And cancer, well, we have about 10% cancer, but that is because we are a tertiary reference center, so we get all these cancers. So that makes no sense. But in consecutive series, if low grade dysplasia in your series is less than 2%, then you are on the safe side. If you have lots more, and I'm not talking about 2.5 or 3% or 4%, I'm talking about 10%, 15%, or 20%. If that is the case, have a discussion with pathologists. So fortunately, we have all this AI. That is perfect. But let me warn you, the upper two slides show very nice pictures, and these AI algorithms, they see more than we could see with our human eyes. The blue areas in the right-hand picture, that is degenerated squamous epithelium. It's very, very hard to see this on the left-hand slide in the, sorry, on the H&E level. So these AIs, algorithms, they see more than we could see without any immuno in our slides. So that is good. So let's see the lower case. The lower case is from Amsterdam, and they had a perfect system. 100% sensitivity, 100% specificity in their AI algorithms. And it worked in 100% of the cases, by the way. But after a certain point, 0%. It did not work at all. And they didn't understand what happened. So they went back to the slide, and it turned out that it was the red dots the AIs were reacting to, because the pathologists marked all cancer cases with 2 red dots. So the AI was more clever than anybody else, because they realized just the red dots and called it cancer because there were 2 dots on the slide. Once another pathologist came with cases and no dots on the slides, the AI couldn't do anything anymore. So be warned that there may be false positive cases, and it's not clear how many wrong cases you have to annotate to manipulate these algorithms. It's not clear. It's really not clear. But the more cases you have, the better it works. And there's no doubt, as you can see also here, with all these heat maps and the distributions of the cells, that this works. It works. All of these systems on the market, they work. The risk ratio, so to say, it's not really high for finding neoplasia, but that is probably reality, and that depicts that we were too poor with our consecutive series finding 20%, 15% of low-grade dysplasia, when the risk of neoplasia is so low, even depicted by the AI, obviously annotated by expert opinion leaders and pathologists in pathology. So in conclusion, high-grade dysplasia or dysplasia can be differentiated even in biopsies. And the WHO classification is incomplete. There's no doubt about this. And I told you also about the basal membrane and all these other criteria, single cells, desmoplastic stromal reactions, they're not working well. And that AI may be a game changer for the future. And then we hopefully end up on a higher level of agreement in pathology, and not having the situation like nowadays, ask 3 pathologists and you get 4 different opinions. So this is a real problem. And I hope this is not end of the discussion, and there will be further discussions in the future as well. So we will see. Thanks a lot for listening. Thank you.
Thank you, dear Professor. Thank you for such interesting presentation. We really enjoy it. And we have approximately 10 minutes for decision, question, and answers. And I will ask the audience about the questions now. Okay, just stay with us extra 10 minutes. Okay, thank you. Колеги, будь ласка, у кого питання? У кого? Ще раз? Я не пам'ятаю, що ви спитали. Подвоєння мускулярних модів? Подвоєння.
Hello, thank you very much for your presentation, dear Professor Vieth. I'm Barretts from Ukraine, and I have a question about duplication of lamina muscularis mucosa in cases of Barrett. Is it a C of Barrett esophagus when we try to differentiate this fragment of biopsy was taken in stomach or in area of Barrett esophagus or not?
Very good question. It makes a lot of sense in surgical terms, whether you're in the esophagus or still in the stomach, because then you have to consider different lymph node resection techniques. But I think it's possible to differentiate whether a biopsy is from the stomach with intestinal metaplasia goblet cells, maybe based on Helicobacter pylori infection, or from the esophagus. I can do it. In the vast majority of the cases, I'm pretty sure my diagnosis is correct. And all these diagnoses where it says if this biopsy was taken from the esophagus, then it's probably Barrett's, or if this biopsy was taken from somewhere else, it's probably not Barrett's. I know these diagnoses. I can read them when we receive cases also. I don't like that. So I think we can differentiate. The trick is that Barrett's, it's not normal gastric mucosa. That looks different from architecture, from cytology, from the distribution of the goblet cells. And when you have the luck that you see esophageal glands in the biopsy, then you know exactly that you are in the esophagus and not in the upper stomach. So this is it may get very difficult when you have hernias, because then some parts of the stomach may have slided into the esophagus, but that's a different issue. Okay, I hope this answers your question with a yes, it's possible and it makes sense.
Yes, thank you very much.
Okay, and the next question about the type of dysplasia. You just covered a lot of type of dysplasia, but in our routine practice, when we receive the report from our histologist, Barrett esophagus without dysplasia, or Barrett is low grade or high grade. But there is a fourth type, indefinite for dysplasia. If you can in your type, so we sometimes receive that type of dysplasia also, but we know that after 6 months, after effective treatment, we just need to repeat gastroscopy and take biopsy.
Yeah, I don't use that term. It's very rare that we say, whether we state that we can't say whether it's dysplastic or whether it's reactive. That's very rare. It's less than 5 times a year, and we have 65,000 gastroscopies per year. So we have a lot of cases, and we have less than 5 cases among these 65,000 where we are not sure about the diagnosis. I hate the term indefinite. I know that in some centers it's an own entity summing up to 20% or so of all cases. But I'm against this this entity, this term and this entity. I'm a pathologist, so I like to have a yes or a no, and there is no gray zone. It's yes and no. And I think it's better to go for something, yes or no, and then change your mind after it turns out that something is different. But if you're unsure as a pathologist, I think we give a comment, and the comment is, please, we are unsure here. Set the patient on 8 weeks high dose PPI, and then come back and we decide yes or no. So this is, you can do, but as I said, it's less than 5 times a year. The other term I do not like at all is basal crypt dysplasia. That's a term that sort of polluted the literature, and most of the pictures in the initial publication by Rob Otzi and Lomo can be explained by a cancer that is just adjacent but has not been biopsied, and you see just the basal infiltration, or it's clearly reactive. There is none of the pictures in that publication that cannot be explained otherwise. The group around Robert Otzi, and I was unfortunately a part of it, started to introduce this now in the colon as well. I think this is totally wrong, but this is my personal opinion, and maybe I'm wrong. I'm just using water to cook, but so to say, but those are the terms I hate most. So indefinite or basal crypt dysplasia, those 2 terms, try to avoid them. Try to find a way to avoid it. This is not an optimal setting, so to say. Okay.
Oh, okay, thank you very much. But as I have information, maybe it's a dismiss for me. You know better, of course, than me. So there is a Vienna classification of morphology parts of in Barretts esophagus, and the indefinite of dysplasia is mentioned in Vienna classification. Am I right?
Yeah, but it's wrong.
It's wrong.
It's very easy. It's wrong. I'm a man of strong words. It's wrong. Period.
Okay.
I don't need this. I don't use it.
Yes.
And as I said, in most lesions, when you have a tiny focus, when you're unsure, and you go back to the lab and request a P53 or P67 or whatever, the lesion is stepped out, and then you end with the H&E only. And the best part is that in almost all publications, it's called P53 overexpression. It's no overexpression. It's an accumulation of this protein in the cytoplasm, and this or the nucleus. But it's not an overexpression. This is just wrong. It's an accumulation. I'm half German, so therefore I can be very precise on these things and have very strong words. Now think about a full German.
Thank you for your direct answer. The next question, I think next question for you, Georgi. Can you switch on the microphone? And maybe to you, maybe Professor Stefan will help us also to realize these points, because before 2024, we have information about to take the biopsy during Barretts esophagus protocol. 4 biopsies every 2 centimeter level. Every 2 centimeter, each 2 centimeter, we just need to take 4 biopsies, yeah? But 2024, there is an AGA guideline which suggests us to take biopsy every 1 centimeter and to start to take the biopsy during Barretts esophagus, not from 1 centimeter from gastroesophageal junction, but directly from gastroesophageal junction every 1 centimeter. So in your case in Switzerland, will you have a fellowship? Maybe in Georgia, you can take your experience. How are you taking biopsy during the Barretts esophagus? CIAT protocol, or it's an updated AGA protocol?
We taking using Seattle protocol and taking from every 4 quadrants for 1 or 2 centimeter lengths of it. So, and we are moving up in all 4 quadrants to use. So we are using Seattle protocol, yes.
Not directly from the gastroesophageal junction. You just move up 1 centimeter and beginning to take the biopsy.
Yes, if there is Barrett's esophagus, yes, we are. Mhm,
Okay, thank you.
mhm.
So about RFA, do you use in Georgia RFA? You have Georgia in Georgia RFA?
No, we don't have because of cost of it. We don't have it yet.
You told us that you make RFA first, then remove the mucosa and the next RFA. So this is a one procedure to RFA.
Yes, this is one session. So first we do RFA, then remove mucosa using cap, and again we use RFA. So this is one session for patient.
Thank you. And is it any role of argon plasma coagulation?
Yes, so you nowadays you can choose between argon plasma or cryoablation or RFA, but I think there is no significant difference which one is better or not. They say plasma is less painful for patient. For APC, it can be cheaper, more RFA. I think this is my opinion.
Thanks a lot, Professor, for your fantastic presentations. Dear Professor Ziewald, questions for us. Do you prefer endoscopy for routine video gastroscopy or another technologies? Because we have not endoscopy in Ukraine. On Tbilisi you have, I know, one scope, but for you, it's routine or it's additional information for your patients? Thank you.
I think we have this endoscopy, but to be honest, for the daily clinical practice, this is takes too much time. The point is, with regard to the imaging, we are on a limit somehow. So we can have 1,000-fold magnification. But the problem is still we can only observe the mucosa. We still have no technology to observe the submucosa. And that's why I think we have somehow reached a limit. So we use the endoscopy for specific cases. But to be honest, I think, yes, it will be difficult. I think one point we are focusing at the moment, I think you have more experience in the Ukraine with all the different kinds of Helicobacter gastritis, atrophy, and intestinal metaplasia. I think maybe endocytoscopy will play a role for the risk stratification in such patients. I think maybe endocytoscopy may help. Our best scope at the moment is also an Olympus scope. It is the XZ1200 zoom endoscope, which has a wonderful white light. It is very sharp, and you can make perfect images with regard to magnification.
Thanks a lot.
And one question from the audience, from our gastroenterologist. If you see atrophic gastritis or maybe the local metaplasia and there is no H. pylori infection, do we suggest any medicines, any drugs, just to renew the mucosa?
Actually, no. So I think when you do, to be honest, as I said, maybe you are already more ahead than us in Western world because we have more problems with the esophagus, and you have the typical Helicobacter gastritis with atrophy, etc. So I think when you perform the diagnosis, you have to decide, is this stomach at risk or not? And actually, I think there's no medicine to treat the atrophy or intestinal metaplasia. You only need time for the endoscopy, and you have to follow up the patient that he doesn't develop early cancer.
Thank you. Thank you very much, dear colleagues, for your time once more. We appreciate that you just tell us yes, and you are not against to have with us the online Zoom conference. So maybe our colleagues want to tell some words for you. Thank you very much. Thank you very much. And hope to see you in Ukraine soon. Okay,
Thank you.
thank you.
Thank you.
Thank you very much.
Thank you so much.
Yeah, also from my side, thank you so much.
Thank you.
Thank you.
Have a nice day.
We asked also to admit that your channel is very famous in the ex-Soviet Union part, and you made a great job to introduce this channel. You make a great job for education, and congratulations and thank you for Olympus to supporting this, because nowadays I think it's very important to use the new media, and this you showed us perfectly how to do it.
Thank you.
Thank you.
Thank you for everything.